First off, I want to thank the brave men and women who work behind the wall. I want to thank them on a national level because their job goes unrecognized.
How do they try to turn a guard?
Well, correctional officer. Sorry, I apologize. But correctional officer.
How you guys doing today? It's Anthony Gangi. Welcome to another episode of Tier Talk. You know, guys, a few days ago, we did a great discussion with Dr. Ann Spaulding, kind of broke down the coronavirus just to kind of give us some facts. And what I wanted to do was I wanted to continue that discussion and talk about how, or basically what happens once you test positive for the coronavirus, COVID-19. And I want to kind of break down what it is and basically also how could that affect our workplace, our prisons, and our jails. Now, last week we had the discussion with Dr. Ann Spaulding. She's back again. She's going to kind of break it down. So it's like part two of that discussion. And we also have Russ Hamilton as well, who's been following everything about the coronavirus and how it's affecting our prisons and jails. So we're definitely going to have a very good discussion. But if you don't mind, Russ will go first. Russ, do you mind introducing yourself to our audience?
My name is Russ Hamilton. I started with California Department of Corrections and Rehabilitation back in 1989 at San Quentin State Prison. I ended up doing a total of 27 years, eventually transferring to another CDCR facility and promoting to sergeant. After I retired, I went back to work again for a different department, which was a small juvenile detention facility in Northern California. And now I spend a lot of my time. I have a Facebook webpage called Keepers of Chaos. That's with a K. And we do lots of content, knowledge, and training for corrections professionals across the United States and across the world.
Yes, I actually did a video on that, posted it up today. Russ was able to give a breakdown of what that group's about. So if you guys get a chance, check out that video. It was posted right before this one and very informative. It talks about making the community work. And right now, if anything, we need each other. So it's good to have that talk because we're educating and we're informing each other. Also, it is my pleasure again to introduce Dr. Ann Spaulding. Now, guys, again, if you haven't seen the episode we did a few days ago, you should check it out. It's a very important episode because it's kind of like part one. You're going to need to understand that before we move forward with this one. But with that said, hey, Doc, you mind introducing yourself to our audience?
Sure. I'm Dr. Ann Spaulding. I'm an infectious disease physician. I have been in corrections for 24 years. After I finished my training in internal medicine and infectious disease, my first job was as medical director of the Rhode Island Department of Corrections. So I simultaneously gained experience both in prison medical care and jail health care. Since it's a combined system. I was there for 5.5 years. I went from there to the Center for Disease Control. I've also spent some time in the Georgia prison system, Fulton County Jail, and currently for the past 15 years, I've been in academics at Emory University. I'm an assistant professor in the School of Public Health, and my work focuses on the health needs of jail and prison populations.
Well, I would like to thank you firsthand again for your service and your dedication. I'm sure Russ would like to do the same thing.
Absolutely, man. It's always great to have someone who's a professional like you that can come in and set us straight because we are not the professionals on this part.
Can I just thank you guys? I mean, it's just you guys are doing the number of years you all have put in the field in service of public safety. It's just to be commended also. So you all have done your work and giving back to society too. So it's this is mutual admiration time.
Well, if I must say, what a great way to start an interview. You know what I mean? I mean, it kind of, and we need this right now, guys. We need to lift up our spirits. You know, we want to kind of take our mindset out of what's going on just a little bit, just to kind of enjoy life a little bit, even in the strenuous times. But guys, we come back from our sponsors. We do have a lot to discuss. And I think it's going to be a very interesting topic. We're definitely going to break down this disease or virus once you test positive and how it affects us at the prisons and jails, how it will affect the population. So guys, now if you haven't, the show Tier Talks for you, brave men and women that work in corrections. So please subscribe, interact, engage, comment, hit that bell. That bell is going to notify you every time I post a video. We'll go to our sponsor. And when we come back, we're going to be talking about what happens when you test positive. Stand by.
I wanted to attend a university that had an intelligence program. I wanted to look at problems different. I wanted to increase my critical thinking abilities. AMU offered those avenues to expand. Obtaining your degree as an adult, you're actually paying yourself and investing in yourself. You can't put a dollar on it, it's priceless. It's something that can never be taken away from you.
American Military University. Learn from the leader.
Guys, inmate manipulation is a course that is highly needed. It's the process that's so slow moving and subtle that you don't realize it's happening. When inmates choose to manipulate, they manipulate our need to react. Situational awareness and insight is going to save your career. It's going to save you from doing foolish things. Listen to your gut. So the more insight we have, the more we can recognize what isn't so overt, and we can correct our behavior before we fall into a trap that we can't get out of. If you allow an inmate to pull you out of your prescribed role, you are opening up a door for a host of problems. Inmate manipulation, the psychology behind inmate manipulation. Available now. Link in description. All right, guys, and we're back. Okay, so the first question I want to toss off is going to go over to Dr. Spaulding. Hey, Doc, do you mind telling us specifically what is the coronavirus and then what is COVID-19?
Well, coronavirus is actually a group of viruses, and most of the coronaviruses that infect humans are very mild infections. Those are the alpha coronaviruses. There is a second group that can infect humans. Those are the beta coronaviruses. The new coronavirus that we are worried about is one of the latter. It's the beta coronavirus. It's very similar to SARS and MERS and the viruses that caused epidemics a couple of years back. And it is a infection that is airborne transmission, and there are some people who get it and are asymptomatic, and then, as we well know, there are some people who get quite ill with it, and it has been lethal in some individuals, that it can be a fatal infection. If coronavirus is the name of the organism that it was the name of the pathogen that is infecting people, COVID-19 is the name of the disease itself. So it is, we talk about the coronavirus, there's a name that I think sometimes confuses people, but we can just call it the coronavirus, and COVID-19 is the name of the disease itself that was first described in China and has since gone around the world.
Now, if I may, before we get to Russ, there is one question where you mentioned that we had SARS in the past and other concerns. I mean, in the facilities, we faced TB, influenza, chickenpox. Why is this one taken so serious?
I think there are two things that make an infection dangerous. One is how severe the disease can be in the individual, and the other is its ability to spread. So we can look at a disease like measles, and for every single case of measles, on average, that case will transmit the infection to somewhere between 11 and 14 people. So you get one kid in a class of unvaccinated kids, very soon everybody has. Measles can be fatal, but most people get measles and survive. It's very sad to see when there are cases of measles that leads to death in an individual, and it does happen. But for the most part, even though it's highly transmissible, is generally a self-limited disease. So there are diseases that are that have a much higher mortality rate than COVID. And I can think of something like Ebola. However, the typical Ebola case does not infect as many individuals as this coronavirus seems to infect. And this transmission has been fast. It's been multiple people are getting infected. And it's a combination of both easy transmissibility and some mortality that makes this such a dangerous infection to have, especially in congregate settings.
In our environment, obviously, it's like a ticking time bomb. At any time, something can go from small to worse. And the reason why I've been doing these shows is because I think that a lot of people are afraid of the unknown, and they're kind of running with what's being said on the news and, how it's sensationalized. And it's great to have shows like this because we're able to bring people back to what's reality, what's realistic. But why do you think it's important right now for us, especially in the profession of corrections, to have shows like this where we're able to give people the facts and not just kind of let them run with whatever's sensationalized in the news? I mean, you've been a supervisor, you have to maintain control. How hard is that if people are not running with the facts? They're running with, the sensationalism that the news tries to put through.
Well, you're absolutely correct. And what we're really facing here is the unknown. And human animals, we're designed to fear the unknown. And so, the more knowledge that we can bring to it so that we know how to effectively deal with it, that's when we're able to tamp down on that. There's nothing, more incendiary perhaps than the prison environment, because, you can go from 0 to 100 in an instant if there's fear. And that's what we're facing with potentially with inmates, especially, is they're fearful of what's going on. They have little or no control of what's going on with their loved ones outside the fence. And they have little or no control even over their own lives inside that fence. And so that's one reason why communication is so important. We as corrections professionals, we're getting trained up by people like Dr. Spaulding here, so that we know what to fear and what not to fear, and how to attack it head on. That does some to alleviate it, but when it's something that's unseen and you really can't quantify it, there's still an awful lot of fear out there.
Yeah, I like what you said too, because when you have that unknown, it's kind of hard to react properly, because the thing is, you got to have a level of control. Your staff, the inmates got to see that you're in control. And the thing is, the only way you're going to get control is when you have that knowledge and that information. Now, I noticed that we talked about the preventive measures, and that was pretty big last week. The preventive measures, that's what people wanted to learn. Are we doing enough? And I was telling people, you could do the best you can, but, the episode kind of said that you have to prepare for the worst. So yes, you prepare for the worst. You could still be hopeful that it doesn't happen, but the end result is don't be oblivious to the fact that it could happen. So the topic today is, the next step is, what happens once you test positive? So, Doc, I'm going to kind of forward this question to you. So let's say that right now we have an employee, let's say that's working in corrections, very immediate environment. And let's say they were sent home with symptoms, and then we just find out a couple of days later that they tested positive. What's the first thing that we need to do as management to make sure that we kind of, limit the spread?
So I think the first thing to do, especially for those who are in a supervisory position, is I think there would be fear that once you know of someone personally who's infected, all of a sudden this becomes a lot more real. And I did invite one of my colleagues who is infected to see if he wanted to participate. And unfortunately, even though he's been very active on Twitter these past couple of days, so I know he's not totally incapacitated, he actually hasn't gotten back to me yet on the old-fashioned email. But I think for some individuals, there is a mild illness. There's some individuals that have a very severe illness. But once you know somebody who has the infection, all of a sudden this goes from being a very theoretical condition to something that feels a lot more real. All of a sudden there's someone specifically that you're praying for and hoping for a speedy recovery. And it's a lot different than just reading the statistics on the internet every day, listening to yet another press conference. So I think I can imagine if all of a sudden there's somebody in your work environment who is sick, and all of a sudden it seems like it's at your front door.
Yeah, and it's also a bit scary because the place that you're used to, you tend to look at a little bit differently. With that said, so when you get an employee that tests positive, right, what does management now have to do to protect everyone else?
Well, I think some of the issues are things that should have been done regardless of what the test result was. We are now starting to get more test kits and more test availability here in Georgia, but when someone is ill and appears to have COVID, we need to make sure that those who are in contact realize that they were in contact, and they need to be monitored themselves for symptoms. At the beginning of this, we were saying, okay, you work in a hospital, you got near somebody who has COVID, and you were so close and you weren't wearing your protective gear, why don't you go home and watch yourself for 14 days? And first responders, you responded to a call out to the fire department, you have come with your truck, and you were happened to be in very close proximity of someone who ended up being diagnosed with COVID. Well, if this is going to be occurring over and over again, we can't send every single person home, or else there will be nobody doing the shift whatsoever. And if we had no firefighters out, we're putting the city at danger. If we have no one in corrections, we're putting the city in danger. If we have no one who's doing EMT or being a police officer, there comes a point where just because there was an exposure that may have been a very small exposure and low probability, not everyone can go home. So I think we do need to be monitoring for symptoms. Generally, symptoms appear, on average, it's 5 days afterwards. The shortest period seems to be about 2 days. I think one of the things that we need to question is between exposure and a symptomatic state, there may be a short window, kind of a prodrome, before someone has a full-blown condition where they may be infectious. The question is, are you infectious the second that you were exposed? Are you infectious maybe 1 day after you're exposed? I think probably we're going to find out that if someone is exposed, let's say 4 hours into the shift, I think it was highly, highly unlikely that the person will be infectious 1 hour later. So I think probably we can have people continue their shift, but whether or not people can quarantine, stay at home and watch for symptoms, whether or not that's just going to be impractical, I think we may be getting to the point where only the most extreme exposure will be the people who we'd want to have stay home. But we want to watch for symptoms. And if someone who's been exposed starts getting symptoms, they need to go home and isolate themselves. Or if they start showing symptoms and go downhill fast, then they may need medical care, in which case they don't go home. They would go, if they wake up and all of a sudden they're a lot worse than 4 or 5 days into the infection, then they should seek hospital level care after they call the hospital and let them know they're coming.
Me and Russ have been going back and forth on our Facebook groups, and I know one of the concerns are, and maybe Russ could help me out with this, was one of the concerns that people are having is that they feel that, why are we waiting for someone to test positive before we start sending people home? And that was kind of what you touched on, where you may not be infectious at that point, but we are technically I think the reaction from most of the departments is that they have someone that could be symptomatic, and then they wait a couple of days, and then the person comes back positive, and then the reaction is, okay, everybody they could have had contact with or exposure with now is to go on quarantine. And Russ, am I right? A lot of the staff is thinking, well, they think that's too late, correct?
Well, they're thinking that that's too late, and there seems to be a lot of discussion out there about what different departments should or shouldn't be doing, because apparently there's a lot of different protocols in place. And I'm really not sure if all of them understand exactly what the protocol is. But as you were talking about, yeah, whether or not that window of infection, when is it? How do you decide when that person actually has to go home? There's also a big discussion on whether or not they should all be wearing masks all the time inside the housing units. And it's caused for a lot of angst among people, because people are very concerned about, bringing this home or themselves becoming incapacitated in some fashion. So I would just would like to, hear what's a good baseline for what we're doing in several of these different things across the spectrum.
I like how Russ and you both touched on, or definitely Dr. Spaulding, when you touched on the staffing where, you may not be able to send everybody home because, in these essential positions, you need these individuals, but the staff have a reason to worry when, someone tests positive and now they're wondering why. Well, we were exposed to this person a week ago when you sent them home. Why were we not sent home a week ago? Why were we not quarantined a week ago?
I think that's a factor. Why weren't we sent home a week ago? I think that's a factor of the fact that we do not have a rapid point of care test that is commercially available. There are some tests that have been developed in other countries that are point of care tests that will give better understanding of whether this influenza-like illness is actually COVID-19. We also we have this PCR test, and that's a test that looks for the virus itself, not just antibodies to the virus. It's looking for the pathogen rather than looking at like footsteps showing that the pathogen went by at some point, which is an antibody test. And we only have the test looking for the pathogen itself. It has been set up in such a way when it was first rolled out where it would take 3-4 days to turn around. There's now a new protocol where the test result can be finished within and be available within 3 to 4 hours. And that is coming to communities around the country that will be able to get rid of that long waiting period to find out what's going on. So a lot of this is just a function of the tests. I think we have to look at the likelihood that somebody could have the real deal. I think if somebody has had exposures, if you're working at, let's say, Rikers, which has so many infections right now, and you have the characteristic symptoms after being on a housing unit where somebody was infected, or you have a coworker who was infected and you were in their face or they were in your face, whatever, and you develop the symptoms, the likelihood those symptoms are due to the beginnings of COVID are much higher than if you're in a jurisdiction where there's little COVID. You happen to be in the maybe looking at the cameras all shift where you're sitting in a room all by yourself. You live alone. The likelihood that the sniffles is full-blown COVID is much less likely. So I think we have to figure out what is the likelihood that this illness is COVID as we wait for the test. And until we've got much greater testing capacity, it's kind of a probability game. And I think in an area where there is a high likelihood, we need to be undertaking the isolation much and the quarantining much earlier than then the minute the test comes back positive. I think we're going to still have some folks come back with positive results that were totally unexpected. Again, what I have heard, and again, this is a very rapidly changing field, is that the people who are most symptomatic are most infectious.
I want to ask, so like if I get quarantined, what are the symptoms that I should be looking for or feeling where I know, okay, this is starting to turn into something more serious?
So the symptoms that people should worry about are obviously the ones that we keep on repeating: the fever, the shortness of breath, and the cough. However, there are some individuals that have other symptoms, and ones that have been described in the articles that are coming out. There's some individuals that have a runny nose. There's some people that have a sore throat at the beginning of the infection. And then a lot of younger people, the only symptoms might just be some vague abdominal pain. There's some people that have diarrhea. So I sure have described a lot of common symptoms of a lot of common infections. So it's, I would say more information is needed, but it's not just the respiratory symptoms. It could be these other symptoms too. And I think we're probably going to find more people have uncharacteristic presentations the younger they are. It seems like those who have the bad infections in their lungs as a primary symptom and primary manifestation of the disease, that may be among older people, but there certainly are young people with the classic presentation. But sore throat, abdominal pain, diarrhea are also things that I would think should prompt someone getting back to their primary care provider. Temperatures should be taken twice a day while you're under watchful waiting, just to make sure that they remain normal.
Russ, you had mentioned before about the mask. I think a lot of officers feel, or a lot of staff feel, that that mask is universal precaution and it will protect you, especially if you're working in a unit where there's a possible chance you could be exposed by COVID. Russ, what's your thoughts on staff really relying on that mask?
A lot of places are facing a shortage on that. And, I don't know what the best, the best protocol is for that. If it were me, I would probably want one, even though I know that it's probably more along the lines of protecting the inmate if I were to have something than protecting me if they've got something. But that's why I tend to want to always defer to the healthcare professional and tell me what is the best practice.
What do you have, Doc, on that?
We think that continuously wearing a mask when you're not around people who are symptomatic, infected people who are symptomatic, and you're just wearing the mask day in, day out, letting it get moist from just continually breathing on it, and it's probably doing very, very little good, if any good at all. So the one thing we know is just continuously wearing the same old ragged mask day after day is probably not preventing disease. Is there something that we should be doing to decrease the likelihood that somebody is going to be exposed to the coronavirus? I think there seems to be some advice that is changing every time you read guidelines. I think we're going to have more definitive guidance in this area very, very soon. Whether or not somebody who is screening individuals coming in should wear goggles and masks and gloves. I think probably we're going to find out that that's the best practice. There was a while where we thought someone screening should be wearing
gowns and gloves and goggles, and it looks like that's not necessary. The gown is probably not something that's necessary. I wish this were clearer. In a medical setting, when you are trying to find out who presenting to your emergency room, presenting to the front door is infected, a couple of days ago, you could not find out from the CDC guidelines exactly what was being recommended. They're trying to get it nailed down, trying to get it straight. And I think this is one of the things that makes this disease so terrifying is it's not measles, it's not polio, it's not a disease that's been around for so many years that we have a lot of data about what are the manifestations that are associated with high infectivity. We are dealing with some unknowns. So I haven't answered your question about wearing the mask. When do you wear the mask? In the guidelines that came out, and since you and I last talked, we do have the interim guidelines from CDC for people working in detentions, and it can be found online. If you just Google CDC and coronavirus and detention or corrections, it will come up. These guidelines will come up. There is a helpful chart at the end that has recommendations of what should be worn for what particular circumstance. So you can just look at that table at the end. They probably were overly conservative, and I know that today or the next day they're going to be scaling back a little bit, but it will be something that is going to become clearer and clearer with time.
Now, when you have an inmate that, let's say, is highly symptomatic, and they're in a restrictive housing, like the highest level of custody, and when moving that inmate, they have to be shackled and cuffed, that inmate should be provided with a mask, because obviously, first off, he's symptomatic, they should have a mask anyway, but secondly is when the inmate's cuffed and handcuffed, they can't protect their cough. They can't, cough into their arm, or so obviously I would believe definitely minimal officers that work those close custody areas where all movement of inmates is very restrictive, cuffed up and whatnot. Those units should be provided with masks in case you have inmates that do show to be symptomatic. But what's your thoughts on that, Russ, real quick? Do you believe that, when those officers that are working those close custody units where those inmates are only moving by shackles and cuffs, do you think that we should automatically have those units supplied with masks?
Yeah, I would always want that, because when if there's a good chance that a guy is infectious like that, I would always want to be able to have a way to protect my staff, because a lot of times you're doing escorts where you've got 2-on-1, because it's bad enough that these individuals are that dangerous, but they're that much more dangerous when they're infectious like that. So I would always want that. And, a thought occurs to me, and I don't know whether this would make sense to everybody, but I was just thinking that, maybe instead of a mask, one thing that we have a lot of, especially in some of these lockup units or stuff, are the face shields. And the face shield may not seem very protective, but it sure reminds you not to touch your face. And so I was just thinking and just throwing it out there that maybe there could be some protective or preventative value in having that. And it's something that the inmates definitely would not freak out about as much as if you were wearing a face mask during your shift, just the, clear plexi.
Yeah, and we have the means to clean those off. We clean them anyway when the inmates are spitting on it or whatnot. Also, maybe even the mask supplemented with the face shield. Would that work, Doc? Would the mask be suffice, like the face shield?
I think if the face shield was just covering the face, and there was some area here where things could get in underneath the shield, I think that that would not prevent exposure. But I think I think as we're looking at as a clear glass shield, there would be better peripheral vision than some of the goggles that people sometimes wear in medical settings. I think things are still need to be worked out. When there were cases of Ebola that were brought back to the United States, originally people just kind of went into full battle gear, and they had their N95s and their face masks and were totally covered. I know that the unit at Emory developed a new type of head covering that looked more like a beekeeper's hat, where there was a lot of space underneath the covering, and it was just so much more comfortable. I think we will have some innovation in what can be worn with time, so that people can see, they have good peripheral vision, and also that there is not that there's full protection from breathing in the viral particles that would be in the environment.
Now, Doc, what would happen if you had an inmate that could be testing hot, like could have a fever, but refuses to go to medical?
I think we're going to see that. I am not sure how that will be managed. I think obviously the brilliant thing to say is on a case-by-case basis. I think there will come a time when the likelihood that somebody has COVID will be something that could be predicted by certain factors. If we test all of that person's contacts with similar symptoms, they all have COVID, the likelihood that that individual has COVID will be high. So I think what's going to be more difficult to work out is the individual that has some mild symptoms that could be COVID and has maybe a moderate amount of exposure. There will be a time when people don't want to get themselves tested. There are other infectious disease situations where people refuse to be tested, and we don't have a right to test people if they want to refuse medical care. So that legally they still retain the right to consent or not consent to a test.
Hey, Russ, if this happened and you were a supervisor, if the person didn't want to get tested, I would think universal precaution is, okay, well, if I can't force you to be tested, I'm going to put you in medical isolation then, because I can't prove you don't have it, because you're not giving me the opportunity to prove you don't have it. What would be your thoughts on that, Russ, as management?
I would say definitely that would be my default setting, up until someone decided that they were going to override me on it, if they were going to override me on it. But, sometimes one of those things, if you're cruising through your shift and you're bumping up against that weekend, and, that seems like, I'm probably going to defer to my watch commander. But in the meantime, that individual's going to be, isolated. Of course, I'm going to call medical and get them to sign off on it. And then I'm going to let the people that make much more money than me decide what's going to happen on Monday.
Sounds like you'd be pointing the finger at someone like me. Can I force somebody to get a temperature read that's non-aggressive or non-invasive, like what we're doing now, the scan?
The whole question is whether or not getting a temperature scan is a medical procedure. And I think what somebody does at the airport and is putting a device close to somebody, I think one can make a case that that is not a medical procedure. If a correctional officer holds something near somebody, you're just trying to detect whether or not there is heat coming from the body. Is that a medical procedure? If you have somebody go through the metal detector, you're just trying to see if there's metal with that person. Is that a medical procedure? I'm splitting hairs. I don't know the answer to that question, and I think probably I think that's a question for a lawyer rather than a doctor as to what constitutes a medical procedure. I think I would not be surprised that a lawyer would say a correctional officer getting a temperature on somebody is not a medical exam. So possibly, depending on what the lawyers say, that may not be a medical exam. Where you place somebody, I think that the custody has the choice of where they want to place somebody in a building. If somebody wants to have the third cell over on the second tier, and you want to put them in the third tier and not in the second tier, I don't think that's the choice. You don't have a choice of your room number like you're in a hotel. So if you want to house somebody in medical, I think that's your prerogative. If custody and nursing want to house somebody in a room that has solid walls and a closed door and not just bars in front, I think that would be something that would not be the choice of the detained or imprisoned individual.
Right, and that's what I was thinking the option would be, where if you had an inmate that just didn't want their temperature read from medical, one thing is I want to know if we're able to even do that. And second thing is, if they're not going to be cooperative, the thing is I'm trying to help them, like if they don't have it. So now if you're not letting me prove that, then the only action I have is universal precaution. I'm going to have to put you somewhere until you give me the option to prove that you don't have it. But, the question was, and I guess it's something maybe we could find out later on, because I'm sure it's going to happen, where you're going to have an inmate that's simply going to not want his temperature read in a non-invasive manner, just a simple read. And I'm very curious to see if we can, as medical, or, I'm assuming I'm pushing real on medical, if medical can go ahead and say, no, we're mandating that, especially at this time, you have to get your temperature read. But because you're not letting us read your temperature, this is where you're going to be placed. And knowing the lawyers, they'll be like, oh, well, that's retaliatory. No, it's not. It's for the safety of the population.
As far as precedents about where you place somebody, I know that there are individuals who have refused to get the bubble underneath the skin testing for TB, the purified protein derivative, the PPD test, tuberculin skin test. There's some individuals who are Rastafarians who say that I don't want to have anything that is a foreign substance placed underneath my skin. And it is possible to place that person in isolation until they either let you test them or their time is over. So there is that precedence for people refusing to be tested for TB. As far as what you would do, you can treat somebody as if they have the disease. There are two issues with that. First of all, that's not the universal precautions, just basically means that you are treating somebody as if they had a bloodborne disease. That's the medical definition of universal precautions. It's what you do for everyone. You do need more precautions than just what's called universal precautions if you think somebody has a airborne pathogen. And that's just when we say universal precautions, it has a specific connotation in medical speak. But what you're saying is treating somebody as if they had the infection. Yes, that could be done. Now, if I were really upset with being incarcerated, and I have buddies who also were really tired of a particular officer, the smartest thing for us to do if we wanted to act up is not just have one person pretend that they were coughing and complained of a fever and refused to have their temperature taken and then start complaining of shortness of breath. If I were really trying to act up, I would probably get at least 10 of my buddies to have the same symptoms, because we know that there are only 9 isolation rooms in the building, and we can easily outnumber the number of isolation rooms. That it can work for one person. If you have one person who's acting up, it's not going to work out if you can get enough folks to pretend they have the same symptoms, because you're going to run out of isolation rooms.
Hey, Doc, I love the fact that you mentioned that. Russ, I could picture people manipulating housing by saying they have the coronavirus just to get out of general population, right, Russ?
I would imagine that it's already been tried. I imagine there's somebody already who's needed to PC up because they have a drug debt, because they're not in good with the gang anymore, or all those other reasons that we know that a person has to go into protective custody. And I'm sure that it's already been done and tried and probably been successful. So it's just one of those things that we always deal with in corrections. It's just another hurdle. It's just another challenge. And we're going to go through, do what we have to do, and sort it all out and come out the winners, hopefully.
But I like what the doc notices, that it limits your resources when people are playing the system. By simply, you mentioned the isolation, also the people that are going to be required to do the evaluations, and the custody it's got to transfer. Now you have a guy that really has it, and this guy that's faking it is getting all the resources. One of the other questions, before we get into when the person starts clearing up, I do have some questions about that. But one more question about the testing for coronavirus or COVID. Is the testing for that invasive? Because is there like a similar to a TB test? How do they test to see if people have coronavirus?
So the test that's being used for the detection of the virus itself, the viral particles itself, right now is a nasopharyngeal swab.
Check for nasal obstructions. Open swab package. Gently insert the swab into the nostril. Keep the swab near the septum floor of the nose while gently pushing the swab into the post-nasopharynx. As a visual reference, the swab should be inserted about half the distance from the opening of the patient's nostril and the ear. Rotate the swab several times. Gently remove the swab and perform the test according to the manufacturer's instructions. If the specimen testing is not performed at the point of care, refer to the manufacturer's instructions for transport and storage recommendations.
In order to do the proper collection, you need to stick something that kind of looks like a Q-tip, basically a cotton swab, up the nose and quite deep, and turn it around several times. And it's not a comfortable procedure, and people tend to cough or when people are getting this test collected. So it's not an easy procedure. It's hard to do properly if someone's fighting you, and if somebody is not just fighting you because they're uncomfortable, but fighting you because they don't want to be tested, it's going to be very hard to collect. So the testing right now is this nasal pharyngeal swab up the nose, and it is difficult to do. Eventually, we should have either a blood test or some other easier means to test people. When we start getting antibody tests, that's going to be a lot easier. We're kind of stymied right now by not having a great testing modality.
All right, now, Doc, and before we move on to, I guess, what happens when the person starts to clear up, I do have some questions about that. Russ, do you have any questions about the testing or the quarantine itself, or anything that you're curious about before we move forward?
No, the only thing that I would say is that I've heard the test described as shoving that thing all the way back and then taking a right at the eye is the way it was described earlier today, and it does not sound like it's a pleasant sort of thing.
Oh my God. I know one of the big questions right now is basically when someone goes through it, are they cleared to go back to work? How do you discontinue the isolation and start moving them forward? Has there been any updates on that?
Yeah, so there were some updates at the beginning of last week on when somebody who's under isolation can return to work. So the guidance looks at both the time since the illness onset and the time since recovery from the illness. So if you have, you want to make sure it's at least 7 days have passed since the symptoms first appeared, and at least 3 days, 72 hours have passed since the recovery has
occurred. So you want to have at least, you want to make sure that it's been at least a week since you first had the symptoms, and then at least 72 hours since you have had a resolution of the fever, so that you have no fever, even without taking Tylenol, aspirin, anything that is a fever-reducing medication, without acetaminophen, whatever, and that you have 3 days, 72 hours of improvement in your respiratory symptoms, so that you're not, you've not been coughing and coughing and coughing. You haven't been short of breath. So let's say I came down sick tomorrow, on Friday. I would be out for at least until next Friday. If I was sick Friday through, let's say, Friday to Sunday, I was still sick. Then on Monday, all of a sudden, I felt great. It was about 10 days after I first got sick. I have to be well for 3 additional days before I could go back to work. So that's what you would use if you are in a situation where there's not testing available. It's simpler if there are tests. If you have testing, you can show that you are having tests that are negative. So it's a pretty good sign that the virus is no longer present. So you want to have resolution of the fever without using, even off of Tylenol, you still don't have a fever, and your respiratory symptoms are better, and that you've had a negative result on a molecular assay, the PCR assay for COVID, from at least 2 consecutive testing times. And this is when, just with the nasopharyngeal swab, that are collected at least 24 hours apart, that is good enough to say you're ready to go back from work. And basically what you're testing is, are you producing the virus in your respiratory tract? And if you're not spewing out this virus that could infect others.
You know what, Doc, real quick, just want to touch base on that. So that would be a big concern. I think we need to get more education on that in the future about when people are able to go back to work, because Russ, I mean, you have to admit, Russ, there's not much on that right now.
Yeah, that's something that that I would imagine that your HR department or something like that is going to have to read those guidelines and figure them out and try and implement that. So far, I haven't seen anyone that I know of that's had it and come back to work. But then again, we're only 3 or 4 weeks into this thing. So,
and I think it's really the burden is on the provider writing the notes. So there's a limit to what HR doesn't play doctor. So there may be individuals that have some other conditions, like let's say somebody has something that might be embarrassing to them, like ulcerative colitis, and they have diarrhea all the time. It's just that they don't talk about it. You don't want human resources to be figuring out when your symptoms of diarrhea got worse. I mean, there's some things that you need to have the doctor's note. So on the CDC guidelines, on the webpage, in the section for healthcare professionals, there's a whole section called Discontinuation of Home Isolation for Persons with COVID-19, interim guidance. And it basically gives a situation, what happens if you were diagnosed by symptoms and you don't have testing, when can you say you're good enough to go back to work? There's another section on what do you do if you do have testing, and that's where it says that you have to be at least 7 days since your first test, if you had a test that clinched the diagnosis, 7 days since the symptoms if you were tested because you were symptomatic, and at least the
two negative tests at least one day apart from each other. And then there's a section on what do you do if you didn't have any symptoms and you were only told that you had COVID because you had a positive test. So thinking of someone like Rand Paul, Senator Paul got himself tested even though he didn't have any symptoms. So if you've not had any symptoms, you don't use like symptom onset, you can discontinue the home isolation, go back to work when at least 7 days have passed since the date of the first positive test, and they have had no illness whatsoever. So there's all these kind of combinations and permutations depending on the circumstances that are on the CDC website.
Now, Doc, you're going to send me a link to that right in the email, correct? And what I'll do, guys, is I will put the link to that in the description just so you guys have, a little bit more knowledge.
I think what we need to remember is the vast majority of people who get this infection get it and get over. And it can seem terrifying right now. The evidence we've got from China is that the majority of people who get this infection do get better. An ounce of prevention is worth a pound of cure. As much as we can do to prevent it, we'll certainly be in a better place. But we also want to remember that while it is fatal, the majority of people do not succumb to it and get over it. And also we believe that there is protection after an infection. And if for those who like to give to society, the fact that those persons probably have some immunity to getting a new infection may mean that they're going to be able to give back in a way that people who have not had the infection and developed immunity to it are able to give back. So there certainly are plans and if you read the correctional guidance, there are certain roles that people can take on if they have had this infection and have survived.
That's actually a little bit more uplifting than what we're usually getting right now, because obviously the news runs with their sensationalism. Hey, Russ, do you have any questions for Spaulding, Doc Spaulding, before we go?
Yeah, I just have I have one or two quick questions. So if I were to get the illness and I get a diagnosis through a test or whatever like that, obviously I'm young enough and healthy enough right now. I'm probably not going to end up in the hospital. What are some of the supportive care that I would need to do for myself at home while I'm self-isolating?
From what I've heard, it's basically, I think the things that we normally do when we get a viral illness, that fluids and rest and just symptomatic syndromic guided therapy. For people who have congestion, we take decongestants. If people are coughing, there are cough suppressants. I think it's just treating whatever symptoms are there. If you're having fevers, you feel better if you're on fever reducing agents such as Tylenol. And generally being with people that love you, I mean, usually that does make things bearable. Having someone to care for you. We just need to have patience and do what we can. I mean, I think it seems like just being able to get caught up on rest is one of the best things we can do to protect ourselves when we have something like this.
Thank you for that. I've been reading a lot on this thing just because I want to know, because I feel that eventually a lot of us are going to get it. So anyway, that makes me feel, because I feel I can take care of myself, But, you know, I think there's a lot of people out there that are worried that it's an automatic hospital sentence at the very least, and we know that it's not.
I think one of the things, if I can just close with this, and you probably will want to get a close-up on this just by, and I'll send you a screenshot of the New England Journal of Medicine from this week. It's actually the issue that came out yesterday. My husband, who's also a physician, was just laughing at this. There's an article defining the epidemiology of COVID-19, studies needed. And he said that what a ridiculous title for an article. Of course, this is what doctors always say, more research is needed. And but I think there's a truth in that we do need to get more information, and we'll eventually get it sorted out. But we're in this very difficult situation right now where we are short on information.
I think, again, we're going to get through something. We're going to make it through. I think the key right now is just to get information. We'll do more shows like this again where we're just getting information out there to kind of alleviate the fears of the unknown. Because even me, you know, once we have a show like this, I feel a lot better. And then all of a sudden, the next day, my mind wanders a little bit. And then we have to go back and do another show to feel a little better. But again, the best I can do right now, the best Russ can do, the best you can do, Doc, is just to get information out there, let people get themselves back into reality, move away from the sensationalism, and just hopefully go back to that normal routine. And eventually this will pass, and it'll just be a moment in history that we'll never forget. But as always, guys, the show is Tear Talk. If you haven't, please subscribe, interact, engage, comment, hit that bell. That bell is going to notify you every time I post a video. And stay safe, everyone.
Whoa.